Okay, let's unpack this. We are diving into the emergency department. I mean, it's the highest stakes environment in medicine, isn't it?
Absolutely.
It's where these life and death decisions are made in seconds, not hours. And there's this constant tension. You have to be fast, but patient safety, well, that's non-negotiable.
Mhm.
Our mission today is to look at the practical framework that's designed to manage that exact tension. We're looking at two really crucial documents from the Royal College of Emergency Medicine, RCEM,
Right.
the Best Practice Guideline for Invasive Procedures from October 2023, and the training side of things, the Specialty Learning Outcome, SLO6, which defines competence for these skills.
And for any of you working in NHS emergency departments in England, this is, well, it's essential stuff. This new invasive procedures document, it came about for a very specific reason.
Go on.
The National Safety Standards for Invasive Procedures, 2 NatSSIPs 2, they updated their guidelines. And they started referencing the ED and minor procedures. But, and this is the crucial bit, they did it without any formal input from EM specialists.
So people on the ground were worried?
The concern was immediate. I mean, if you try to apply these strict theater principles, which are designed for, controlled elective environments, to a chaotic trauma bay,
Yeah.
you're going to fail the patient.
Right.
So the RCEM guidance is the elegant solution here. It's not about ignoring safety. It's about creating a robust but really pragmatic framework that actually fits the reality of the ED.
Without demanding these resource-heavy, time-sinking steps that just belong in a scheduled operating theater.
Exactly.
That's the core distinction we need to explore then. The difference between sort of safety theater and actual pragmatic safety. And NatSSIPs 2 is all about standardization, harmonization across the whole hospital.
Mm.
But in the ED, when you have a patient hemorrhaging, you can't exactly call a full team timeout that involves, verifying implant serial numbers. It's just not going to happen.
No.
And here's where it gets really interesting, because RCM laid out 5 specific, achievable recommendations for EM clinicians. So what are these foundational steps that keep the ED safe, but also swift?
Okay, so the first rule is consent. You need verbal or written consent, unless the clinical situation means you have to act immediately in the patient's best interest.
The emergency situation.
Yes. And just a quick note for anyone working near the borders, the legislation for adults lacking capacity is different in Scotland compared to the rest of the UK. So you have to be aware of those subtle but crucial legal variations.
Okay, that's number 1. What's next?
Second is site or side agreement. This is a mandatory check.
Yeah.
2 healthcare practitioners have to independently agree on the site where it's appropriate.
2 practitioners.
And here's a crucial internal safety check.
Yeah.
One of those practitioners must be ST4 or above.
Right, let's pause on that, because for listeners not deep in the specialty training pathway, what does ST4 really signify? I mean, in terms of seniority and competence. Does mandating that level ever create a bottleneck when every consultant and senior reg is already tied up?
That's a fair challenge. ST4 essentially means you're in your senior training years. You're past the core ACCS training. You're now specializing in emergency medicine. So you're seen as a proficient, capable, and accountable senior registrar.
So it's about accountability.
It is. The
You'll-
requirement isn't meant to cause a bottleneck. It's to ensure that accountability and experience are there. If you let a junior verify the site alone, that accountability is diluted. The ST4 or above check ensures 2 sets of senior eyes are on the plan.
Understood. Okay, what about the rest of the 5?
Number 3, team awareness. The clinician in charge must confirm that any assistants know the procedure, the planned approach, and the plan for post-procedure monitoring.
Makes sense.
4th is checklists. Their use is strongly encouraged for auditable compliance, even if it's a tailored, ED-specific checklist. And 5th is training. Your induction and any specific training must explicitly cover these safety issues.
And what defines the RCEM approach is what they removed from the standard theater protocols, isn't it?
Yes, exactly. Unlike in theaters where a full multidisciplinary team is standard, the RCEM document gets that many ED procedures can be done safely by a single clinician.
Yeah.
Forcing a full team for, say, a simple joint reduction under sedation is just.
A waste of resources.
It's resource inefficient and completely unnecessary.
Which brings us to the famous checklist modifications. RCM customized the NatSSIPs checklist for the ED. What were the 2 most critical omissions that really show this pragmatic approach?
Well, the first critical omission was removing this step. Verification of implant.
Yeah.
This is a huge time saver, and it shows real awareness of the ED's role. We're not implanting prosthetic hips or cardiac devices. We are doing immediate life-saving or stabilizing procedures.
Hmm.
That step just doesn't apply, so it's pragmatically cut.
And the second one?
The second modification concerns site marking. In a scheduled theater procedure, you mark the site clearly. But RCEM specifically removed the requirement for routine site marking on a patient coming into the ED.
And the example they gave for why this was removed is just excellent. Tell us about the fascia iliaca block scenario.
Right. So imagine you have a patient with a hip fracture. An EM doctor performs a fascia iliaca block, a FIB, for pain relief.
Mm-hmm.
If they mark the site, that mark could be misinterpreted by the surgical team later on. They might think that surgical consent for the main operation had already been obtained because the site was marked.
A dangerous assumption.
A very dangerous ambiguity. Removing that step keeps the responsibility for marking with the definitive surgical team.
That's a great insight. It connects the immediate procedure to the whole patient journey. Now, despite these rules, the ED is unpredictable. What happens when a clinician just has to bypass these checks to save a life?
This is the essential accountability measure. When high patient acuity or extreme time constraints prevent you from following the recommendations, say you need to do an open chest drain now and there isn't an ST4 free for the check.
You just have to crack on.
You do. But the clinician must document their rationale for noncompliance in the patient's record. The guideline gives you permission to act, provided you close that loop with robust documentation afterwards.
And that documentation is the safeguard for the patient and the clinician. And I like that the guideline doesn't just focus on doctors. The ED nursing team is absolutely central to safety.
They are critical. The guidelines explicitly state that the nursing team must know what constitutes a high-risk procedure and are empowered to challenge any clinician, regardless of seniority, who proceeds without the relevant safety checks.
That really embeds the safety culture at ground level.
It does. It ensures checks aren't missed just because someone is rushing or tired.
Okay, let's move on and look at the sheer range of procedures we're talking about. This framework has to be flexible enough for everything from suturing a wound to a resuscitative thoracotomy.
Exactly. The list in the guideline is extensive. It covers lumbar puncture, lateral canthotomy for orbital compartment syndrome, acidic fluid drainage, various types of central venous access, and those highly time-critical ones, like resuscitative thoracotomy.
And the guidelines are careful to distinguish between minor and major procedures, referencing the NatSSIPs 2 definitions. Can you clarify that for the ED setting?
Sure. Minor is defined as procedures under local anesthesia with small incisions in non-theater areas. But the guidelines immediately clarify which procedures are explicitly labeled as major in the ED.
Such as?
This includes open thoracostomy, or what we'd often just call a chest drain insertion, and of course, emergency resuscitative thoracotomy.
Why is it so important that an open chest drain, which is pretty common in trauma, is formally designated as major here?
Because it triggers the highest level of adherence to the safety checks, even under pressure. By calling it major, we acknowledge its higher risk profile, the potential for catastrophic complications.
And the need for that ST4 site check and thorough documentation.
Precisely. It prevents the procedure from being casually thought of as just another chest drain.
Right.
And we have to mention a high-risk category that isn't technically invasive, procedural sedation. Because the potential for respiratory depression and airway loss is so high, procedures using sedation or regional anesthesia, like a Beers block, are considered high risk.
So they have to comply with the same requirements where applicable.
They do.
Which makes the need for a focused safety brief absolutely mandatory. So what are the non-negotiable elements of that procedural sedation safety brief?
It has to be rapid and focused. The brief confirms the clear roles of everyone in the room, the intended plan, depth and length of sedation, confirmation of the correct side if applicable. Yes, and a check that all equipment, especially suction, is working. Confirmation of where rescue devices and drugs are, and a quick discussion of any anticipated problems for that specific patient. It's a rapid-fire mental checklist to get the safety net up before you start.
Moving from immediate safety to long-term competence, let's pivot to the training framework, SLO 6. This is where RCEM defines what an EM specialist has to be able to do. What stands out to me is the acknowledgement that many of these skills are high acuity, low frequency, ALO skills. This means you might do them for the first time after you've completed your training. How does SLO 6 structure competence for that?
It creates a structured system of trust measured by entrustment levels. It starts at the ACCS level, where trainees focus on knowing when to do a silting or chest drain or a lumbar puncture, and developing the basic psychomotor skills under direct supervision.
And then they move up?
As you progress, you move into core EM training. Intermediate training means you're at level 3 entrustment. You're deemed proficient. You can do the skills safely and in time, but the system still requires a safety net.
What does that safety net look like?
Your supervisor is on call from home, able to give directions over the phone, or they can come to the bedside if direct supervision is needed. You're proficient, but you're not fully autonomous yet.
And the final goal is level 4.
Exactly. Higher training aims for level 4 entrustment. This is the autonomous expert. You're expected to not only perform the procedures yourself, but to supervise and guide colleagues. Crucially, you can manage these skills with no supervisor involvement at all.
And that leap from level 3 to 4 is based on documented assessment, DOPS, simulation, logbooks.
Robust, documented assessment, absolutely.
Let's focus on those ALO skills. For intermediate trainees, how does the RCEM ensure they're ready for procedures that might only happen once every few years, like a resuscitative hysterotomy?
The requirements are mandatory. For those highest acuity, low-frequency skills, resuscitative thoracotomy, lateral canthotomy, pericardiocentesis, resuscitative hysterotomy, the guidelines mandate specific e-learning and simulated practice at the intermediate level 3 stage.
So simulation is the proxy for competence.
It has to be, since you can't guarantee real-world exposure. And this extends to advanced airway management, too, which requires ongoing observed practice and simulation for things like surgical airway and RSI. For RSI, they expect you to log about 10 procedures a year to maintain currency.
And it's not just the big trauma skills. Even fracture and dislocation manipulation involves a huge breadth of skills: shoulder, hip, mandible, ankle, all needing sign-off. Let's finish with point-of-care ultrasound, POSUBES. This is probably the most quantifiable skill set, isn't it? Competence is measured in hard numbers.
POSUBES is the perfect example. To get signed off at level 4, you have to maintain a logbook showing your exposure. The guidance gives expected numbers for proficiency: 10 scans for echo and life support, and 25 scans each for AAA assessment, shock assessment, and EFAST exams.
So what does this all mean when you pull these two documents together? It means that as an EM doctor in the NHS, your practice is covered by this dual framework.
It is.
One for the immediate, auditable, pragmatic safety checks in the moment, and one for verifiable, measurable, long-term professional competence.
That's the essential contract, really, between the clinician, the college, and the patient. It ensures that adherence to pragmatic safety standards, which, successfully sidestep those unsuitable theater protocols, is matched by a defined commitment to skill mastery across the whole demanding spectrum of EM.
So whether you're an ST4 making sure that two-person verification happens, or a consultant managing a critical case where documentation has to wait, this framework gives you the parameters you need to operate effectively, confidently, and safely. Here is a final thought for you to consider. The guideline permits non-compliance with the checklist if the situation is time-critical and the rationale is documented. Think about the operational challenge here. How do we standardize the quality and the completeness of that documentation when a clinician is physically and mentally depleted after a successful but incredibly high-stress intervention? It puts a huge burden on them to justify their choices retrospectively, creating a real tension between bureaucracy and, well, life-saving urgency.